The next talk is Major Obstetric Hemorrhage, the Challenges and Solutions by Dr. Arvind Palanisamy. Dr. Arvind Palanisamy is an Associate Director in Obstetric Anesthesia in Harvard Medical School. Over to you, sir.
Good morning, everyone. I'll be covering a really wide-ranging topic on major obstetric hemorrhage. Because I have only 25 minutes, I decided to focus only on the problems and new ways of thinking about obstetric hemorrhage. So it's always nice to start with some statistical background. You know, how common is postpartum hemorrhage? And this is data from the WHO. Almost 6% of all deliveries, whether it's vaginal or C-sections, are complicated by postpartum hemorrhage. If you look at statistics that's specific to India, this is one of the latest set of data from the Registrar General of India's survey. Almost 1 out of 4 maternal deaths in India are caused by postpartum hemorrhage, which is 25% of all maternal deaths. But the problem is not just mortality. Morbidity continues to be a big problem, and mortality is just the tip of the iceberg. So for every 1 maternal death, what is the morbidity cost associated with it? There are no data that's specific to India, but I came across a lot of other papers. And so just to put things in perspective, for every maternal death, there are almost 6 other mothers who could have died, but somehow managed to escape. There are about 15 unplanned emergent hysterectomies, again, to save the lives of mothers. And there are about 350 women who require massive blood transfusion, and almost 75% of them will require ICU admission. So it's very clear that morbidity associated with postpartum hemorrhage is also equally important as mortality. So I've addressed 4 main themes in this talk. So I'm going to talk about recognition of postpartum hemorrhage. I think we actually do a poor job at it. The second is I'm going to talk about coagulation problems in bleeding during pregnancy, and then talk about some advances in hemostatic therapy and resuscitation, and finally talk about the morbidly adherent placenta, which is placenta accreta and percreta, which I think we are seeing more commonly these days, especially if you're doing a lot of obstetrics. So the problem with postpartum hemorrhage is that there's a lot of denial that it's happening, and partly because the physiological changes in pregnancy prevent rapid assessment and recognition of postpartum hemorrhage. So we are actually very poor at estimating blood loss, and I'll talk about that in a second. And we often do not recognize change in vital signs quickly enough to intervene. So that's the clinical side of the problem. And from the lab side, there's another problem. Because the coagulation test, when someone starts to bleed, you send labs to check what the hemoglobin is and what the fibrinogen is. And it takes about 45 minutes to 1 hour to get the data back. So you're actually basing your treatment on data from 45 minutes to 1 hour ago, and the patient would have bled almost 1 to 2 liters by then, and the clinical situation would have been changed. So there is always a role for point-of-care tests, and I'll be talking about that in a second. So regarding estimation of blood loss during pregnancy, one of the common questions is how accurate are we? And there's a lot of data out there suggesting that if you're visually quantifying blood loss, just eyeballing the suction canister and the surgical operating field, we actually underestimate blood loss by almost 30%. So if you think that the blood loss is about 1 liter, it's actually 1.5 liters. So we actually do a pretty poor job at estimating blood loss. Gravimetric method is popular, and what they do here is actually they measure the weight of the sponges and then deduct the weight of the dry sponge and then calculate the possibility of hemoglobin loss. It's more superior, but the problem is you need to train the nurses to do it, and there's actually a decay of skills over time. So if you don't do this often, the nurses actually forget how to do this and how to do this quickly enough for you to get an understanding. So it's practically not a good solution. So to address this problem, there's a new monitor that's come out in the United States, and it's actually becoming very popular. It's called the Triton system. It's actually a very non-invasive system. It's based out of an iPad. So it comes with a camera, and what you do is just take a picture of the sponge that's soaked with blood. And what it does is it sends the picture to a cloud, and they actually extract information based on the degree of staining of the sponge. So they use the power of machine learning, and they actually, within 10 seconds, you get the amount of hemoglobin that's there in the sponge. So based on the number of sponges, you can easily calculate the amount of hemoglobin loss. And the best part of it is that you get the results back within 10 to 15 seconds. And we don't have any randomized trials or good clinical data yet, but from the limited studies that have come out, it seems to be as good as the gravimetric method and almost even better than gravimetric method in some of the studies. So I think this, because it's non-invasive, it's easy to use, I think it's becoming increasingly popular, and I think this is probably going to be the future of estimating blood loss, not just in obstetrics, but also in other specialties. So the second part is when do you know that the vital signs are abnormal? So as you know, tachycardia often occurs during labor and delivery and during C-section. So when does it actually become abnormal? And again, that's a big problem because trainees sometimes don't pick up on subtle changes in vital signs. And one of the tools that has come up recently is called the shock index. You know, the concept itself is not new. It's been around for about 50 years. It's used mostly in critical care medicine. It came out of Germany. It's nothing but the heart rate divided by the systolic blood pressure. So for example, if someone has a heart rate of 100 and a systolic blood pressure of 100, your shock index is actually 1. And it's typically used to assess the severity of hypovolemic shock. In pregnancy, because you have a relative tachycardia and a small decrease in blood pressure, the shock index is actually slightly higher than the non-pregnant state. So the shock index in pregnancy is about 0.7 to 0.9. So people have started to wonder whether shock index can be used to actually identify patients at risk or patients are having an ongoing postpartum hemorrhage, and whether it will help us predict who will need blood transfusion. And there's some data coming out of England. So this is from St. Bart's Hospital in London. And what they found was that if the shock index is greater than 1.7, so just to put things in a very simple way, so if you have someone who has a heart rate of 170 and a blood pressure of 100, so their shock index is 1.7. And these patients typically end up needing ICU admission, and it is also predictive for requiring more than 4 units of packed red blood cell transfusion. So at least we have some index which is now being advocated to look at the possibility of transfusion in these patients. Otherwise, we just give blood in a very random fashion. So there's some evidence that shock index is helpful, and this is something to watch out for in the future. So moving on to coagulation abnormalities, we always talk about bleeding in pregnancy and coagulopathy in pregnancy. And one of the novel concepts that have come due to work from the University of Bristol in England is to look at coagulation problems as 2 distinct entities. Most of the bleeding in pregnancy happens due to tone-related issues. Almost 80% of postpartum hemorrhage is because the uterus does not clamp down immediately after delivery. And the more troublesome bleeding is the bleeding associated with DIC. And so people have actually started to separate out the 2 entities because your treatment actually differs depending on the etiology. So you have a subset of patients, which actually the good majority of patients who actually have normal coagulation even when they are bleeding. So this is uterine atony and genital trauma. Preeclampsia, in the absence of low platelets, typically they don't bleed as much. And then you have the most worrying group, which is the group with altered coagulation. And these are patients with placental abruption. So anytime the placenta is involved, whether it's separating prematurely or if it's stuck, can cause a rapid onset of DIC. So that's something to remember. And amniotic fluid embolism is associated with a very high mortality, again, early DIC, and then HELP syndrome. So this is where it's preeclampsia associated with low platelets. So it's easy to think about coagulation problems in pregnancy as 2 distinct entities. For the most part, the coagulation is normal, but there's a small subset of conditions where you have to be really prompt in recognizing and treating them. So the reason why this has become more of a talk or a conversation these days is because people have recognized that fibrinogen, which we normally use to identify DIC, is now used as a biomarker. And the reason for that is that we all know that fibrinogen plays a big role in primary hemostasis as well as in secondary hemostasis. We know its role in fibrin polymerization. But what we need to know is that the common assay that's used in the lab to come up with the fibrinogen level. It's called the class assay, and it's actually interfered with by if you're giving colloids. So if you're giving heterstarch, for example, you'll get a falsely elevated level of fibrinogen, and it's very misleading. And the second problem with giving heterstarch, especially in the setting of a coagulation issue, is that it decreases the strength of the clot. So these are a few things to consider when you're thinking about fibrinogen. So where does all the studies about fibrinogen as a biomarker come from? So we have a long history of about 10 years now, and there's a lot of data. And I'm just going to highlight some of the data to indicate why fibrinogen is a good marker for bleeding, rather than looking at bleeding and then checking for fibrinogen. So one of the first studies came out in 2007, and what they found was that for every 100 milligrams per deciliter decrease in serum fibrinogen, the risk of severe postpartum hemorrhage increased by 2.5-fold. And if the fibrinogen levels less than 200 milligrams per deciliter, it had a 100% positive predictive value for severe postpartum hemorrhage. So this was one of the first studies, and this has been followed up by many other studies. And the study by Deloitte et al. Actually showed an inverse correlation. The higher the fibrinogen level, the lower the blood loss, and the lower the fibrinogen level, the higher the blood loss during postpartum hemorrhage. And the third study actually looked at fibrinogen levels and the interventions for postpartum hemorrhage, which could be non-surgical or surgical, including hysterectomy. And again, the level of 200 milligrams per deciliter comes up. So if the fibrinogen level is less than 200 milligrams per deciliter, it was an independent predictor, and the risk of having an advanced intervention for postpartum hemorrhage, which could be a C hysterectomy, or could be any of these non-surgical procedures like a suture, B-Lynch suture, or anything intervention of that sort is 5-fold higher. So it's pretty clear that fibrinogen less than 200 milligrams per deciliter seems to be the mark that we are targeting. So how do we recognize fibrinogen? I already mentioned that it takes about 45 minutes or almost an hour to get the levels back. So now people are advocating a role for ROTEM, which is rotational thromboelastometry. It's similar to thromboelastography in the sense that it provides a dynamic assessment of blood clotting. But what's unique about ROTEM is that you have specific tests to identify specific pathways of blood clotting. And one of the common tests that's used these days, especially in the setting of postpartum hemorrhage, it's called FibTem. FibTem, it's basically fibrinogen, and TEM is thromboelastometry. And what they do in this test is actually add a chemical called cytochalasin D. And what it does is it blocks the contribution of platelets to the clotting. And then you run the assay. It's pretty much similar to thromboelastography, but the clot that forms in this assay is solely related to the concentration of fibrinogen because you've already eliminated platelets from the mix. And so one of the first studies, again, came from this group in Bristol, and what they found was that the amplitude of the clot at 5 minutes, and if that amplitude is less than 10 millimeters, it was an independent predictor of severe postpartum hemorrhage. So this was the first study that actually used ROTEM in a prospective manner to show that if the amplitude is less than 10 millimeters, there's a strong association with bleeding. But what you need to remember is that it's only a surrogate marker for serum fibrinogen, and people have actually come up with different algorithms to give you a sense of what the actual fibrinogen level is. So the advantage of the FibTem A5 is that within 5 to 10 minutes, you actually get an estimate of what the fibrinogen is compared to 1 hour if you're waiting for lab values. So there's a clear benefit to using this device if you have it. So if you have a FibTem A5 value of 15 millimeters, the assumption is that the fibrinogen level is somewhere around 300. But what we're looking at is the FibTem A5 of less than 10, and that indicates that the fibrinogen level is less than 200 milligrams, and that's where you have to intervene. So moving on to advances in hemostatic therapy and resuscitation, I'll be talking a little bit about tranexamic acid because I think people who are doing obstetrics must have come across this large women trial involving over 20,000 patients. I'll be talking about that in a second. So this study was sponsored by the Bill and Melinda Gates Foundation and the London School of Hygiene and Tropical Medicine, one of the large-scale randomized trials looking at the efficacy of tranexamic acid, which is an antifibrinolytic agent for prevention of postpartum hemorrhage. And the intervention in the group was that they gave 1 gram of IV tranexamic acid, followed 30 minutes later by another gram if required. And the primary outcome was mortality due to bleeding or the need for unplanned hysterectomy. And what they found was that the mortality due to postpartum hemorrhage was actually decreased in the tranexamic acid group compared to the placebo group, especially when given within 3 hours of onset of bleeding. So this is actually one of the large-scale trials which have actually shown that tranexamic acid is very helpful in this setting. And I think we all use tranexamic acid quite frequently. And I think the advantage of this particular study is that it also tells you that the risk of adverse effects, especially thrombosis and other side effects, are really minimal. In fact, the side effects were comparable between the tranexamic acid group and the placebo group. So if you're doing a large number of obstetric patients and high-risk obstetric patients who could bleed, I think tranexamic acid is something you could definitely consider prophylactically. You can either do 1 or 2 grams. It's up to you. So we talked a lot about fibrinogen, and we always think at what level should we start replacing fibrinogen, either with fresh frozen plasma, a cryoprecipitate, or one of the latest advances is actually fibrinogen concentrate. So the optimal treatment threshold, at least when I was doing my residency in Ames, the recommendation was that you replace fibrinogen if the level is less than 100 milligrams per deciliter. So this is based out of trauma literature. But based on all the studies I've shown you, it seems to me that keeping the level greater than 200 milligrams per deciliter is going to be helpful. Remember that in pregnancy, the fibrinogen level increases by 30 to 50%. So I don't think it's proper to equate trauma patients with pregnant patients, because trauma patients, their fibrinogen levels are low to start with. So if you're targeting 100 milligrams per deciliter, that's okay. But in pregnancy, they already have a much higher level. So you're actually undershooting by waiting for the level to drop below 100 to start treating. So I think a better physiological approach will be to try to maintain the fibrinogen level between 250 to 300 milligrams per deciliter. So that's all based out of all the literature I've shared with you. So regarding the treatment options, I'm not going to go into the details for lack of time. The most common is fresh frozen plasma and cryoprecipitate. But one of the new advances is fibrinogen concentrate. And the advantage of that is that it decreases risk of trolley because it comes as in the form of a powder, which you can immediately mix and administer as a bolus. And the best part is you know how much of fibrinogen you're giving. For example, if you're giving fresh frozen plasma, you really don't know what the fibrinogen content is. We know approximately what's in there, but we don't know whether it's functional, whether it's working. Whereas if you're dissolving it and giving it, you know exactly how much fibrinogen you're giving to the patient. So it's very easy to titrate. So it's actually a human plasma-derived product. It's pasteurized. It comes as a powder. Usually about 1 gram in a bottle. And if you do not know the fibrinogen level, which is most often the case when you start to see bleeding, especially in patients with placenta creta, the recommended dose is about 70 milligrams per kilo to start with. And the other advantage is that there's no risk for any thrombotic complications, because you're basically replacing fibrinogen rather than pushing fibrinogen to a supranormal, supraphysiological level. You're just replacing it. So the risk of thrombogenicity is pretty low. So is there any evidence that instituting fibrinogen helps? And so this study actually comes from the Liverpool Women's Hospital, where I did train before I moved to the US. And so in this particular institution, prior to 2012, any postpartum hemorrhage was treated in a very formulaic way. So if there was a postpartum hemorrhage, all of these patients got 4 units of Paxils and 2 units of FFP and cryoprecipitate if required. And then in 2012, they introduced ROTEM-guided management of postpartum hemorrhage. And what they did was, once they identified postpartum hemorrhage, they ran the samples for the FIPTEM-A5 test. And if the FIPTEM-A5 level was less than 7 millimeters, what they did was they gave 3 grams of fibrinogen concentrate as a bolus. And you can see clearly that the shock pack phase, which is the phase before introduction of ROTEM, they actually used a large number of blood products. Because it was not guided, everyone got the same amount of transfusions. They actually ended up using a large number of red blood cells and FFPs. But once they instituted ROTEM-guided management, the number of transfusion products actually decreased over the next 2 years. So this is actually one of the first studies to show the utility. So if you're thinking that there's a cost associated with ROTEM, yes, it is definitely there. But if you're a large volume center and if you're doing liver transplants and a lot of other cardiac cases, maybe you can actually use that technology to manage bleeding in pregnant patients. So one important note to remember, fibrinogen concentrate, even though they're useful in treating patients who are actively bleeding, they're actually not useful as prophylaxis. So if you're just thinking that, okay, a patient might bleed, I will give some fibrinogen and try to prevent bleeding, actually there's no evidence. This randomized study actually comes from Denmark, where they actually randomized patients after delivery to either get fibrinogen or a placebo. And as you can see that there was no big difference in estimated blood loss between the two groups. So as a prophylactic agent, fibrinogen doesn't work. But if you have active bleeding, and especially if the placenta is involved in some way, and you're suspecting that DIC is happening, I think you should somehow think about replacing fibrinogen early on. You don't even have to wait to give the red blood cells. You can start with fibrinogen and then start transfusing as you get the packed red blood cells. A small note about cell salvage. How many of you actually use cell salvage routinely? Okay, I see a few hands. One of the problems with in patients, especially during pregnancy, is that it's mixed with amniotic fluid, and there's always a lot of concern whether you can return that blood back to the patient. We have now special filters, and it's pretty safe to use. And in fact, all the big organizations, including the ASA and the AAGBI from the UK, have endorsed the use. So if you're a large volume center, and if you're using cell salvage for cardiac patients or big orthopedic surgeries, and you have access to that technology, so that's something you can consider, and you can easily use it. And in fact, most of the institutions, the big institutions doing high-risk procedures have already started using cell salvage, so that's something for you to consider. So one interesting tidbit about us is that because you cannot separate out the fetal red blood cells from maternal red blood cells, so there's a possibility you may cause alloimmunization in the mother, because the fetal red blood cells, if they're Rh positive and the mom is Rh negative, you're accidentally transfusing fetal blood. Some of the fetal red blood cells does get into the maternal circulation, so you have to be aware of that possibility, and you have to give some immunization to prevent that from happening. So if you end up doing cell salvage, always check the Rh status of both the mother and the baby, and do the immunization accordingly. So moving on to the last topic, which is the morbidly adherent placenta, which is placenta accreta. So the problem is, if it's diagnosed during pregnancy, it's easy to manage. Yes, there's a lot of interventions to be planned, but it won't take you by surprise. In fact, there are a lot of studies that have shown that if you plan a C-section in a patient who has a placenta that's stuck to the myometrium, and you plan it at 34 to 35 weeks, the outcomes are pretty good. But the problem is, more often we end up in the operating room having no idea that the patient has an accreta, and then suddenly the obstetrician says that the placenta is not coming, it's stuck, and this is where you end up in a problem. So just to highlight the differences between a patient who has already been diagnosed to those who have been diagnosed on table, you see that the median blood loss is about 4.5 liters in a previously diagnosed. So you actually make the preparations. These patients still bleed, but at least you have a good control of the bleeding. You plan things accordingly. But the median blood loss and discovery on table, it's about 8 liters. It's almost 80% more than previously diagnosed patients. And again, the use of packed cells transfusion, again, it's about 7 units required in the previously diagnosed compared to 13 units in the undiagnosed. And the rate of transfusion is almost 60% if you diagnosed it even before you go to the room. But if it's unanticipated, almost every patient ends up getting a massive blood transfusion. So there's a lot of benefit in doing antenatal diagnosis and planning accordingly. So one of the common topics that's come up is the use of interventional radiology. And people have started putting in prophylactic balloon occlusion catheters. And the idea is that you put in balloon occlusion catheters in the femoral artery, take the patient back to the operating room, deliver the baby, and once the baby is delivered, you inflate the balloons, and then decrease blood supply to the uterus with the hope of decreasing blood loss. And there are some studies that have suggested that it's useful, but one of the first randomized studies that actually came out 2 years ago actually suggested that it's actually not helpful. Prophylactic placement of balloon catheters, the problem is that you place the balloon catheters 1 hour to 2 hours before the procedure, and you move the patient around, and so you're not entirely sure if the balloon is properly located. And it gives a false sense of security that you have everything under control. But more often what happens is the patient starts bleeding, you inflate the balloon only for the radiologist to say that, oh, it's displaced now. And then, you're totally dependent on that. And now you have to make a plan B and a plan C. So it gives a false sense of security. And in this particular study, not a lot of patients, only 13 to 14 patients per group. What they found was that there's basically no difference in the rate of transfusion if you put in a prophylactic balloon occlusion catheter or not. There are a lot of uterine sparing interventions, and if you're, again, doing high-risk obstetrics, it makes sense to ask your obstetricians to get trained in all of these procedures because they're all life-saving. The balloon tamponade, it's similar to Sengstake and Blakemore tube for managing variceal bleeding. You just put the tube inside the uterine cavity and then inflate the balloon, and the idea is that the balloon will tamponade the collateral circulation in the lower uterine segment. So it is actually effective in almost 80% of patients, and it can be inserted either blindly or under ultrasound guided vision. So this is something, it's a very easy tool to use, and there are a lot of studies from India where they have modified, they've innovated. Instead of using these expensive balloon tamponade tools, they use condom catheters basically. You can use pretty much it's the same principle, but instead of you just fill it with saline and then occlude the bleeding area. And B-Lynch suture it's a longitudinal suture which wraps the uterus. It's actually named after Christopher Balogun Lynch, who was actually an obstetrician in Milton Keynes Hospital. And every time he came across this patients with poor uterine tone and bleeding, he was wondering what to do. And he thought, okay, let me just put a stitch around the uterus and just tie it. And again, he showed really good success rates of almost 90%. So I think it makes sense for the obstetricians to train in these kind of techniques because you prevent C hysterectomies, which you don't want to do. I'm going to quickly skip through these slides. This is basically ligation, and this is your plan C. If the bleeding is still ongoing, you end up ligating either the uterine artery or the internal iliac artery. And where interventional radiology might be useful if you're having an ongoing postpartum hemorrhage and you've done everything you can, and now you end up in the radiology suite and you can actually embolize the uterine artery. So there is some evidence that it helps, but prophylactically, there's no help from interventional radiology. Just to summarize all the evidence behind uterine sparing interventions, you can see that the success rates are almost 85 to 90%. So it makes sense for obstetricians to train in these techniques to keep them as well as you out of trouble. And finally, a word about resource-limited settings. We often talk about high-end stuff, but the reality on the ground is different. And especially if you have limited expertise to surgical technique or even blood products, because you don't get 4 or 5 units easily. And in these situations, what you can do is that do nothing approach. There's no real reason for the placenta to come out. If the obstetrician is operating, comes across a stuck placenta, there's no real need to take it out. The bleeding starts only when you try to rip the placenta. So just leave the placenta and occlude the umbilical cord, clamp it, stitch up the uterus, and then deal with it later when you have planned for a much better resuscitation. So the advantage of this is that you minimize bleeding, the patient is still alive, but the disadvantage is that patients can get infected. There's a high rate of infection, and it can also cause delayed postpartum hemorrhage due to sloughing of the placental tissue. So these are things to consider, and there's also a really high rate of emergent hysterectomy 2 or 3 weeks later. But at least it will save your life on table. So if you come across this, you can just ask the obstetrician not to touch the placenta, close everything up, and then deal with it 1 or 2 days later when you've made plans for it. Okay? So I'm going to quickly skip through the summary. It's just what I've mentioned before. Early recognition, I think shock index in the Triton system will be helpful. Fibrinogen, aim for a level greater than 200 milligrams per deciliter. Tranexamic acid, now there's good data to support its use, and so is the data for fibrinogen concentrates. Uterine sparing surgery is something which all the obstetricians need to be well versed in. And finally, conservative management if you have limited access to blood products. Thank you very much.